When you take a scalpel to skin, you see the exact depth of your cut. But when you apply an acid or fire laser, you're flying blind unless you know exactly how to read the tissue.
Yeah, that is so true. Welcome to a targeted deep dive on skin resurfacing mechanisms, depths, and endpoints. We're breaking down the practical realities of chemical peels, dermabrasion, and lasers.
The goal here is simple. You need to master the exact depth of tissue destruction required to replace abnormal layers with fresh, healthy tissue. And you have to do it without crossing the line into irreparable scarring.
Because that line between rejuvenation and ruin is incredibly thin. Before you even think about touching an acid or a laser, you have to know exactly what layer of the canvas is damaged.
Right, you have to visualize the skin functionally.
Yeah, exactly. You're not just looking at wrinkles, you're looking at specific structural failures.
Okay, let's unpack this. Think about it structurally. The epidermis is your roof. It's your water exchange barrier, and it's your sun shield, packed with pigment.
And beneath that, attached by vertical oxytalin elastic fibers, is the dermis. That's your structural foundation.
Yeah, you wouldn't rip up the foundation to fix a missing shingle. Say you evaluate a patient with senile ptosis requiring a surgical lift. Pulling that skin tight just gives you tight, heavily damaged skin.
Oh, absolutely. That analogy holds up perfectly in real life. You have to address the barrier itself. And that foundation has two distinct zones you need to recognize.
The superficial papillary dermis and the deeper reticular dermis, right?
All right. The superficial papillary gives the skin its flexibility, and the deeper reticular dermis provides the thick, sturdy support. When you evaluate an aging face, you have to distinguish between two completely different processes.
Natural aging versus actinic damage. Because natural aging is really just a process of global atrophy, right? Every single skin element thins out.
Yeah, the epidermis, the dermis, the underlying appendages, they all lose volume over time. But actinic damage does the exact opposite.
It thickens the skin.
It does. Chronic sun exposure causes reactive thickening. The epidermis builds up a dense, leathery layer. The tissue is actively defending itself against ultraviolet radiation.
You see this constantly on the face, the neck, and the dorsal hands. And you also see specific pigment maladies pop up, like lentogens.
Right. Lentogens are isolated collections of excess pigment. As we age, and as UV radiation damages the cellular DNA, melanin production becomes highly asynchronous.
Because normally, a single melanocyte sitting on the basement membrane distributes melanin to, what, 15 or 18 keratinocytes?
Exactly. It's a highly regulated distribution network. Actinic damage completely disrupts that ratio. You get a massive increase in melanin dumping directly into the keratinocytes.
So to eradicate a true solar lentigo, you have to physically destroy the basal layer of the epidermis. You basically have to wipe the slate clean.
You do. But a really common pitfall here, I see residents confuse that mechanism with melasma all the time.
Oh, yeah. Melasma is an entirely different beast. It drops abnormal pigment straight through the basement membrane and down into the dermis.
Right, it's hormonally driven, mostly in young females. And it's notoriously unpredictable. You can't just burn it off with a superficial peel.
If you try, it almost always comes back worse. You have to block the melanin production at the source.
Exactly. You put them on 2 to 4% hydroquinone and topical retin A. Getting them on that regimen is critical to avoid rebound recurrence.
You know, the underlying anatomy absolutely dictates your healing trajectory. If you keep your destruction superficial, reepithelialization happens really fast.
Right, because the tissue regenerates straight from the remaining intact basal layer. You get a quick, clean recovery.
But the moment you push deeper and destroy the full epidermis, you change the rules of the biological game entirely.
You really do. Now you're relying on lateral migration, and more importantly, vertical migration of epithelial cells crawling up from the underlying dermal appendages.
You're literally counting on the sweat glands and the hair follicles to step up and repopulate the entire surface area.
You are. And if you push even deeper, straight into the dermis, you trigger massive secondary fibroblastic collagen production.
Which is exactly how you efface a deep wrinkle.
Right. But every millimeter you drop into the dermis increases your risk of permanent scarring exponentially.
So since superficial actinic keratosis and dull skin sit safely above the basement membrane, we start with epidermal treatments. The repair is rapid and full face coverage is safe.
We're mostly talking about alpha and beta hydroxy chemical peels here. The chemistry dictates the clinical result.
Let's look at alpha hydroxy acids, or AHAs. Glycolic acid is the absolute standard. It's just a tiny 2-carbon chain.
Yeah, and because the molecular weight is so low, it penetrates the epidermis incredibly rapidly.
But that rapid penetration is exactly what gets people in trouble, right? In real life, glycolic acid often penetrates very unevenly.
Oh, highly patchy. It finds paths of least resistance and dives deep, leaving other areas untouched.
To control that erratic behavior, we often use it in a gel base capped at a 30% concentration with a pH of 3.0 or greater.
Right. Then you have lactic acid. This is a slightly larger three-carbon chain. It penetrates much slower and much more evenly than glycolic.
Because of that safety margin, you can actually push lactic acid all the way up to a 70% concentration.
You can. But here's the key point with AHAs. The frosting endpoint is really indistinct.
Right, you do not get a reliable visual cue that tells you exactly how deep the acid has penetrated.
Exactly. You have to apply them based on strict timing protocols, and then you have to rapidly dilute them with a water rinse to stop the reaction.
Which is why beta-hydroxy acids are sometimes easier to work with, the BHAs. The main player here is salicylic acid.
Yeah, salicylic acid is highly lipophilic. It loves oil. That's why it's fantastic for acne patients with heavy sebum production.
And unlike the AHAs, it actually produces a highly visible, distinct white frost.
It's a very satisfying endpoint. It's even easier to track if you throw a fluorescent woods lamp on it in the treatment room.
Oh, it lights up beautifully. Historically, though, salicylic acid fell out of favor for deep peeling, didn't it?
It did. High concentrations applied over large surface areas carry a very real risk of systemic toxicity. It specifically causes profound tinnitus.
Patients would literally complain of ringing in their ears right on the table, so the specialty adapted. We combined them to mitigate the risk.
Enter Gessner's solution. This is the absolute daily workhorse of superficial peeling.
It gives you the keratolytic benefits of both AHA and BHA, but keeps the concentrations low enough to avoid toxicity.
Every surgeon needs to know this mixture by heart. 14 grams of resorcinol, 14 grams of salicylic acid, 14 milliliters of lactic acid.
All mixed into 100 milliliters of ethanol. You see residents treating Gessner's like a standalone miracle peel, though.
Yeah, but in real life, its true power is as a primer. That's where it shines. It's practically foolproof.
It gives you a light, predictable frost, and because of the ethanol base, it rapidly volatilizes.
Right, flashes off the skin in seconds, so absolutely no neutralization is needed. You control your depth just by counting the layers you apply.
You use Gessner's for initial dekeratinization. Stripping those dead cells allows your subsequent, deeper peels to penetrate perfectly evenly.
Exactly. But fine lines and heavy wrinkles aren't just surface issues. They involve the dermal-epidermal junction and the dermis itself.
To fix those, you have to cause a controlled injury deep enough to trigger that secondary collagen production. We're actively chasing the wrinkle.
And that means taking on significantly more risk. For this depth, we rely heavily on trichloroacetic acid, or TCA.
For true dermal corrections, you're using strengths anywhere between 35 and 42.5%.
TCA is excellent for the cheeks and the forehead. It's highly effective for tightening the thin skin of the eyelids.
But it completely falls short on deep periorrheids, those heavy vertical smoker's lines around the mouth. It just doesn't have the horsepower.
It doesn't. But TCA has one massive clinical advantage over the lighter acids. You can read your depth with extreme precision.
Because it aggressively coagulates epidermal proteins on contact, creating a stark, unmistakable white frost.
Right. You know exactly where you are in the tissue based on the density of that frost.
But when TCA isn't enough, you have to bring out the heavy artillery, phenol and croton oil. This is the most unforgiving chemical peel we possess.
It is absolutely unmatched for obliterating deep periorrheids. It functionally erases them. But the mechanics of it have been aggressively debated for decades.
I've always found the history of this fascinating. Historically, everyone used the Baker-Gordon formula. It was a sledgehammer approach.
Very toxic, and really only suitable for severely thickened, deeply sun-damaged skin. People assumed the phenol was doing all the heavy lifting.
Until Hitter published his work. He proved that the croton oil is actually the active, cytotoxic peeling agent. The phenol is largely just the delivery vehicle.
Yeah, Heder changed the game by mapping out specific concentrations of croton oil, but Stone pushed back later with a totally different evaluation.
Right. Stone argued that the phenol concentration is equally critical, and more importantly, he proved that the physical friction of the application dictates the final depth.
Exactly. How hard you rub the gauze directly drives the caustic chemical deeper into the dermis.
The clinical endpoint here is totally different from TCA2. Phenol and croton oil produce a gray-white frost.
But the croton oil is so incredibly caustic that it causes severe immediate erythema.
And that intense redness bleeds through and often masks the gray-white frost entirely, making it incredibly difficult to read your depth accurately.
Which is why you have to be meticulous with your friction and your volume. If you overshoot the depth, you destroy the melanocytes completely.
Chemicals are great, but you're ultimately at the mercy of the acid's penetration rate. Sometimes surgeons need immediate tactile control over the exact physical depth.
That's when you drop the acids and pick up a surgical power rotary tool, dermabrasion.
We're mechanically sanding the skin using a wire brush or a diamond phrase. Both physically remove tissue layer by layer.
And there's a major histological difference here. Chemical peels and lasers stimulate a compensatory thickening of the dermis as they heal.
But dermabrasion permanently reduces the physical thickness of the dermis. The healing process never completely replaces that lost tissue volume.
Right. And in the OR, you don't have a chemical frost to look at. You're holding a spinning wire brush against someone's face.
So how do you actually gauge your exact depth millimeter by millimeter?
You have to read the bleeding. That is your only viable gauge. When you sand down into the superficial papillary dermis, you'll see confluent bleeding points.
Organized in a very fine lattice stroma. It looks like a uniform grid of tiny red dots. And as you grind deeper into the foundation,
When you hit the deeper reticular dermis, those tight bleeding points spread out. They become widely spaced and highly discrete.
the dermal stroma itself looks coarse and mechanically tough. You have to physically reach the depth of the wrinkle's base to efface it completely.
Common pitfall here, though, the mandible and the neck. I've seen absolute disasters when surgeons get too aggressive over the jawline.
Those are extreme danger zones. The dermis over the mandibular border and anterior neck is incredibly thin.
And worse, there are drastically fewer underlying skin appendages there. Remember the biology of healing. Once you sand off the epidermis, you desperately need those sweat glands to repopulate the surface.
If you sand too deep on the neck, you wipe out the appendages. There's literally nothing left for the tissue to heal from. You leave a massive hypertrophic scar.
Moving away from mechanical sanding and chemical burns, let's look at the laser era, selective photothermolysis.
We're no longer relying on friction or pH. We're targeting water inside the tissue using highly specific light energy.
The physics behind it is elegant. The laser energy hits the target. Chromophore water instantly boils it and aggressively vaporizes the surrounding structural tissue.
The absolute heavyweight champion of this arena is the CO2 laser, operating at a 10,600 nanometer wavelength.
It is a pure heat coagulative ablative laser. The old continuous wave versions created massive thermal char.
So the industry refined it by pulsing the energy. We shortened the pulse duration to stay safely under the thermal relaxation time of the skin.
Which is roughly 0.2 to 1 milliseconds. You have to deliver the destructive energy faster than the surrounding tissue can physically conduct the heat away.
A complete coverage, fully ablative, pulsed CO2 laser remains the absolute gold standard for extreme wrinkle effacement. But it comes with a massive biological cost.
The patient downtime is genuinely brutal. You're looking at a prolonged, messy, highly exudative recovery phase.
And the intense heat coagulation carries a persistently high risk of delayed hypopigmentation and permanent scarring.
Right. So the industry looked for cooler options. Enter the Erbium YAG laser. This system runs at a 2940 nanometer wavelength.
Erbium has a drastically higher affinity for water absorption than CO2. It vaporizes the target tissue instantly with almost zero surrounding thermal collateral damage.
It functions essentially as a cool ablation laser dermabrader.
Yeah.
You strip the tissue cleanly without leaving a bed of cooked collagen behind.
But there's a trade-off. The lack of deep thermal damage means you simply don't get the same massive tightening collagen shrinkage that you get with CO2.
Exactly. So to solve the unacceptable downtime problem of traditional CO2, the industry introduced fractionated photothermolysis.
Instead of burning off the entire contiguous surface, the laser fires in a tight, pixelated grid, creating microscopic columns of thermal injury.
Microthermal zones. The laser punches thousands of tiny holes deep into the dermis, but deliberately leaves completely intact, healthy tissue directly between them.
It's essentially like aerating a lawn. You pull deep plugs of dirt out, but you leave large patches of untouched grass behind.
Yeah, and those healthy patches rapidly expand and help the whole yard heal vastly faster than if you just bulldoze the entire property.
You preserve the vital skin appendages and delicate melanocytes hidden in those untouched bridges of skin.
Which means the reepithelialization time drops from weeks of oozing misery down to a few manageable days.
But downtime is practically eliminated. Patients come into the clinic demanding fractionated CO2 because they think they'll have perfect, wrinkle-free baby skin in 3 days.
But there's a very hard clinical truth that gets aggressively ignored in the marketing materials.
Fractionated CO2 simply cannot match the raw, transformative power of a complete coverage, fully ablative pulsed CO2 laser.
It can't. If you have a patient with deep, severe actinic wrinkles, punching a few thousand microscopic holes will not give them the result they actually want.
You cannot cheat the fundamental biology of wound healing. Massive structural correction absolutely requires massive, contiguous tissue injury.
And anytime you aggressively disrupt the dermal-epidermal junction, you open the door wide to clinical disaster.
Managing the delicate healing phase is just as critical as executing the procedure itself. You've intentionally stripped away the body's primary immunological defense barrier.
Acute infection is your immediate, most dangerous enemy. You have to aggressively monitor for viral, bacterial, and yeast infections.
Let's talk viruses. Herpes simplex, HSV type 1 and type 2. The massive trauma and thermal shock will wake a dormant virus up immediately.
Antiviral prophylaxis is absolutely non-negotiable here. You start them on valacyclovir 500 milligrams the entire day prior to the procedure.
If they break through that suppression and develop an active infection, usually presenting as patchy areas heavily filled with painful vesicles, you immediately bump that dose up to 2,000 milligrams a day.
We drill residents on HSV prophylaxis constantly, but I see a lot of people entirely miss Candida.
Oh, yeast infections. We cover these resurfacing patients in thick, heavy, occlusive ointments while they heal. We're basically building a humid greenhouse for yeast right on their face.
Candida albicans thrives aggressively in that dark, moist environment. Clinically, the healing wound suddenly turns a bright fire red.
You'll see a fine dusting of superficial, delicate vesicles. Do not mistake it for herpes simplex.
You have to treat the yeast rapidly with topical nystatin, often mixed with a mild topical steroid, and it usually resolves cleanly.
Then we have to manage pigmentary changes. This is where patients panic the most. In the early healing phase, the new epithelium has absolutely no protective melanin.
Right, the melanocytes haven't repopulated the surface yet. If that fragile new skin gets hit with ambient UV light, it triggers a massive inflammatory response.
You get severe, dark, post-inflammatory hyperpigmentation.
You manage that proactively by putting them on hydroquinone to chemically block the tyrosinase enzyme and mandate strict physical sunscreen.
Hyperpigmentation is annoying, but it's manageable. But what's the actual worst-case scenario here?
The true nightmare complication in this field is permanent hypopigmentation.
Roasting.
Exactly. When you use contiguous heavy injuries, you can completely wipe out the basal layer of melanocytes. The heat or chemical toxicity physically eradicates them.
And unlike hyperpigmentation, this ghosting doesn't show up immediately in the clinic, does it?
That's the truly insidious part. It might not become fully evident for several months. The surrounding skin recovers its tone, and the treated area turns stark, artificially white.
Because you've eradicated the source cells entirely, once it happens, it is completely irreparable. You have permanently altered their facial canvas.
Well, let's recap the core principles. Superficial problems require surface-level treatments. If the clinical damage is contained entirely in the epidermis, use AHAs, Gessners, or light TCA.
But if you want to actually erase deep structural wrinkles, you have to push past the basement membrane. You have to enter the dermis and ride the bleeding edge of the healing response.
Your choice of chemical, mechanical, or thermal injury dictates the recovery timeline. Every single time you cross that boundary into the dermis, you trade patient downtime for clinical results.
And you heavily flirt with the risk of permanent scarring and irreversible pigment loss, which leaves us with a massive looming question for the future of our specialty.
Right now, every single deep dermal correction we perform relies entirely on physical destruction.
We have to violently burn, sand, or vaporize the protective barrier of the skin just to trigger a secondary scar and collagen response beneath it. We're causing massive trauma just to fix trauma.
Will the future of plastic surgery eventually bypass the surface entirely?
Imagine a novel modality that directly targets and stimulates the oxytalin elastic fibers. Imagine forcing normal, healthy elastin and collagen replacement from the inside out without ever having to destroy the epidermis in the process.
No chemical burns, no weeping open wounds, no devastating loss of pigment.
Until that exact technology arrives, you have to know your acids, know your lasers, and know exactly how deep you're cutting. Think about that the next time you prep a patient for resurfacing.